Welcome to the Funnel Effect.
It's great to be here.
Today, we are opening a file that I think a lot of people, even those in the medical field, view with a mix of reverence and, let's be honest, a healthy dose of anxiety. We are looking at what I like to call the detective work of cardiology.
Mm.
And I don't mean looking at shadows on an X-ray or interpreting squiggly lines on an ECG. I mean the hard-boiled detective work where you actually go to the scene of the crime.
That is a great analogy because sometimes you can infer a lot from the outside. You can, look through the windows, so to speak. But eventually, if you want the absolute truth, you have to break down the door and go inside.
Exactly. We are talking about endomyocardial biopsy. Physically going into a living, beating heart to retrieve answers, we are diving deep into the expert review titled Endomyocardial Biopsy, published in Intervention 2026, Volume 21.
A fantastic paper.
It really is. And before we get into the heavy machinery and the life or death decision-making, I want to make sure we acknowledge the team behind this work, because it's a massive collaboration.
It has to be for a topic like this.
The authors are Enrico Fabris, Aldo Stefano Porcari, Rossana Busani, Maurizio Pinamonti, Marco Merlo, Serena Vacar, Andrea Perkin, Joseph Bartunek, and Gianfranco Sinagra.
That is a powerhouse list. You have the team from the University of Trieste there, Sinagra's group, and they're world-renowned for their work on cardiomyopathies and myocarditis.
So they're the authorities on this.
Absolutely. When they write a review on biopsy, the cardiology world stops and reads it. They are essentially the custodians of this knowledge.
So let's set the stage. To the uninitiated, or even to a patient who just heard their doctor suggest this, endomyocardial biopsy, or EMB, it sounds almost archaic.
It does. It sounds a little medieval, doesn't it?
Right. We live in the age of Star Trek medicine. We have MRI, CT scans, PT scans. Why on earth are we still inserting a long catheter into a chamber of the heart and using tiny metal jaws to physically bite off a piece of the muscle?
It is a fair question, and it's one we ask ourselves. It feels invasive because it is invasive. But the reality is that imaging, no matter how advanced it gets, is still largely looking at the phenotype.
The phenotype. So what it looks like from the outside.
Exactly. It tells you what the heart looks like. Is it swollen? Is it stiff? Is it weak? Is the wall thick or thin? But it doesn't always tell you why.
It gives you the what, but not the cause.
Precisely. Is that wall thick because of a genetic protein error? Is it thick because it's infiltrated with, say, amyloid proteins? Is it swollen because of a virus or because your own immune system has gone rogue and is attacking it?
Things an MRI can't distinguish.
Not with certainty and not at the cellular level. The biopsy gives you the histology. It moves us from guessing based on shadows to knowing based on cellular reality.
It's the difference between seeing smoke coming out of a building and actually sending a firefighter inside to see if it's a grease fire or an electrical fire.
That's a perfect way to put it. And in the era of precision medicine, knowing exactly what is burning dictates whether you pour water on it or chemical foam. If you use the wrong treatment in heart failure, as we will definitely see in the case studies, you can actually kill the patient.
Wow.
That is why, despite the risks, this procedure has evolved from a niche tool into the absolute gold standard for these cardiac mysteries.
Let's trace that evolution because it didn't start as a diagnostic tool for everyone, right?
Right.
Let's get into part one of our breakdown. The history and the why.
Right. So if you rewind the clock about 30 or 40 years, EMB was essentially a one-trick pony.
One-trick pony.
Yeah. It was used almost exclusively for heart transplant surveillance.
So you get a new heart.
Yeah.
And the doctors need to make sure your body isn't rejecting it.
Exactly. That was its bread and butter. You would do routine biopsies on transplant patients to check for rejection grading. And to be clear, that is still a huge part of the volume. We still do that.
But that's not what this paper is really about.
No, the paradigm shift and what this Intervention paper really focuses on is the move toward the unexplained heart failure patient.
Okay, so define unexplained for us. Because most heart failure has a reason, right? A blocked artery from a heart attack, years of high blood pressure, maybe a leaky valve.
Right, those are the usual suspects, the horses. But we are talking about the patient who comes into the ER and they are crashing. They're in what we call cardiogenic shock.
So their body is shutting down.
Their blood pressure is tanking, they're cold and clammy, their organs aren't getting enough blood, maybe they have a wild ventricular arrhythmia. So you do the logical thing, you rush them to the cath lab, you do an angiogram to look for blockages, and their arteries are clean.
So it's not a heart attack.
It is not a classic heart attack. You do the echo, the ultrasound, and the heart is just barely moving. The ejection fraction is terrible. You've ruled out the comments like ischemia. Now you are looking for zebras. The clinical picture is dramatic, it's rapidly progressive, and all your non-invasive tests aren't giving you a smoking gun. That's when you start thinking about a biopsy.
And this is where the most wanted list comes in that the paper talks about.
Yeah.
What are we actually hunting for when we decide to go in with the biopsy?
Well, top of the list is myocarditis, inflammation of the heart muscle. But here is the nuance, and this is a critical insight for you if you're listening. It is not enough to just say, it is myocarditis. That is a bucket term. We need to know the specific flavor.
Because the flavor dictates the recipe for the cure.
Exactly. Take giant cell myocarditis or eosinophilic myocarditis. These are incredibly aggressive, necrotizing diseases. They essentially eat heart muscle for breakfast.
Wow.
But if you catch them early, they are very responsive to heavy-duty immunosuppression steroids, drugs like cyclosporine or azathioprine. You can literally save the heart.
But you have to prove it first. You can't just guess.
You have to, because the other big suspect on your list is viral myocarditis. What if that inflammation is caused by an active viral infection, say parvovirus B19 or adenovirus?
Okay.
If you give that patient powerful immunosuppressants, you have just turned off the body's only defense against the invader.
You basically hand the virus the keys to the castle.
You will turn a sick heart into a dead heart very, very quickly. So the biopsy is literally the tiebreaker between two diametrically opposed treatments. One saves them, the other kills them. You cannot guess.
It is the judge, jury, and executioner of the treatment plan.
It really is. Then you have the other heavy hitters. The infiltrative diseases, things like amyloidosis.
It's a stiff heart condition, right?
Right. Amyloid is this misfolded protein that deposits in the muscle, turning it into something like stiff rubber instead of a flexible pump. But again, you have different types. You have AL type, or light chain, which is basically a bone marrow problem treated like cancer with chemotherapy.
And the other type?
The other is TTR type, or transthyretin, which is treated with totally different drug stabilizers or silencers. You mix those up, and the patient suffers unnecessarily. The biopsy tells them apart.
And the paper also mentions sarcoidosis.
Sarcoidosis is a big one. It's a granulomatous disease. It creates these little balls of inflammation that can get into the heart's electrical system and cause heart block. Again, treatable with steroids if you find it.
So it really highlights that heart failure isn't a diagnosis. It's just a symptom.
It's a syndrome. The biopsy finds the specific disease, and the major guidelines are catching up to this. The ESC, the European Society of Cardiology, they recognize this. They give it a Class D IA recommendation.
What does that mean in plain English?
It means it's not a must-do for everyone, but they're essentially saying if you have rapidly progressive heart failure and there is a reasonable probability of a specific treatable condition that only a tissue sample can confirm, you should really, really consider going in.
Okay, so the why is compelling. It saves lives by dictating treatment. It's powerful. But we cannot ignore the elephant in the room, or rather, the potential hole in the heart. Let's talk about part 2. The stakes, the danger.
We have to be transparent. This is not a blood draw. It is not a routine echo. This is a high-risk procedure. Major complications happen in about 1 to 5% of cases. The rate really depends on the center's volume and the operator's expertise.
That 1% sounds low until it's you or your family member.
Correct. And the complications aren't just minor inconveniences. The big one, the one every operator sweats about, is perforation.
Poking a hole through the heart wall.
Exactly. You are pushing a metal rod into a muscle that is moving, contracting. If you push too hard or the wall is thinner than you thought, you go right through.
And that leads to tamponade, which is a word I've heard that sounds terrifying.
It is terrifying. If you punch a hole, blood rushes out of the ventricle into the pericardial sac. That's the membrane surrounding the heart. That sac doesn't stretch quickly, so the pressure builds up instantly.
Like a water balloon filling up.
But on the outside, squeezing the heart from all sides so it can't fill with blood.
It's like putting the heart in a vice grip.
Exactly. The blood pressure flatlines. You have minutes, sometimes seconds, to recognize what's happened and get a needle in there to drain that fluid, or the patient dies on the table. It turns a diagnostic procedure into a code blue.
And looking at the review, that's not the only risk. They list thromboembolism as well.
Yes, a big one. You are introducing foreign materials, catheters, wires, the bioptome itself, into the vascular system and the heart. You can dislodge a pre-existing clot, or a clot can form on the equipment if you aren't meticulous with anticoagulation.
And if that clot travels.
If you're on the left side of the heart, It goes to the brain, that's a stroke. If you're on the right side, it goes to the lungs. A pulmonary embolism, neither is good.
And you're also threading this gear past the valves.
You have to cross the tricuspid valve to get to the right ventricle or the aortic valve to get to the left. You can damage the leaflets. You can tear the chordae, the little strings that hold the valve together. You can cause severe regurgitation, which just makes the heart failure worse.
And what about arrhythmias?
Oh, almost guaranteed you'll get some. You are poking the myocardium, it gets irritated, you'll see extra beats, what we call ectopi. Usually that's benign. But sometimes you can trigger VTach or VFib, a full-blown cardiac arrest right on the table.
So given this, this minefield of potential disasters, how does the team decide to pull the trigger? It can't be a decision made by one person over a coffee?
Never. The review is very clear about this. It emphasizes the heart team approach. This is standard in modern cardiology for any big decision. The clinical cardiologist, the heart failure specialist, the imaging expert who read the MRI, and the interventionalist who's going to do the procedure, they all sit down.
And they argue it out.
They discuss it. They weigh the diagnostic yield. How likely are we to find an answer that changes therapy against the procedural risk for this specific patient?
And there are hard stops.
Hey.
Right. Conditions where you just say no go, regardless of how much you want the tissue.
Absolutely. There are contraindications. If an echo shows a ventricular thrombus, a clot just sitting in the ventricle, you don't go in, period. You'll knock it loose.
Makes sense.
If the patient's platelets are below 50,000, it's too dangerous. They won't clot if you cause a bleed. And obviously, you have to stop any oral anticoagulants beforehand and sometimes bridge them with heparin. It's a calculated risk, but the calculation has to be rigorous.
Let's assume the team says go. The risks are managed. The patient is prepped. Now we get to the mechanics, part 3. The hardware and the technique. I was looking at the images of the bioptomes in the source material. They look like marvels of miniature engineering, but also a little medieval.
Frockles. They are a bit of both. A bioptome is essentially a long, navigable catheter. It's usually between 50 and 100 centimeters long, sometimes more. At the very tip, you have these stainless steel jaws, tiny little cups with sharp edges.
And there isn't just one type, is there? The paper mentions a few.
Well, it's like golf clubs. You choose the right one for the shot. You have different sizes measured in French. A 9 French is about 3 millimeters wide. It's a big bite. A 4.5 French is tiny. You also have different jaw actions.
What do you mean by actions?
Some are single action, where one jaw is fixed and the other moves to cut. Some are double action, opening symmetrically like a clam. Brands like Cordis, Schulten, Maslanka, they all have slightly different feels.
And the flexibility of the shaft is crucial.
Oh, absolutely critical. If the shaft is too stiff, you can perforate the wall just by advancing it. If it's too floppy, you can't get enough purchase. You can't push it against the wall hard enough to get a good sample. You need that Goldilocks zone of torque and stiffness to navigate the curves of the heart.
The review highlights the long sheath technique as the preferred method. Walk us through that, because it seems like a crucial safety layer.
It is. It's the modern standard. Imagine trying to thread a floppy wire with sharp jaws on the end into a specific spot in a beating heart, and then do it 5 or 6 more times.
It sounds chaotic.
It's dangerous and inefficient. So instead, we place a long sheath, a stable plastic tunnel that goes from the entry point in the vein or artery all the way into the ventricle.
So you establish the highway once and then drive the car back and forth safely.
Exactly. You usually place a pigtail catheter first. That's a catheter with a curled tip that is less likely to poke a hole to map the position safely. Then you swap it for the sheath. Now, there is a critical safety check here that I want you to visualize.
The pressure check.
Vital. Once that sheath is in the ventricle, you hook it up to a pressure monitor. You should see a nice rhythmic waveform matching the heart rate. If that line goes flat, what we call damping, it means that the tip of the sheath is pressed flat against the heart muscle. It's occluded.
And if you inject contrast dye at that moment,
You will hydraulically blast a hole right through the heart wall. It's called staining the myocardium, but often it leads to a dissection or perforation. So the rule is absolute. No pressure wave, no injection, period. You pull back until you see the waveform.
that is a high-stakes safety check. So the sheath is in, the pressure is good, now comes the bite. How do you actually grab the muscle without grabbing too much?
This is where the feel comes in. It's an art. Step 1. You insert the bioptome through the sheath. You only open the jaws once they are inside the sheath.
Why inside?
Safety. You don't want sharp open jaws scraping through a valve or the sheath itself on the way in. You open them where it's safe, then you advance them out of the sheath tip.
Okay, jaws are open, they're out.
Step 2, you advance the whole system until you feel a gentle resistance. You're touching the endocardium, the inner wall. Often the heart will complain. You'll see ectopi, a skipped beat, or a run of them on the monitor.
That's your confirmation contact.
That's your signal. Hey, you're poking me. Step 3, you close the jaws firmly. And step 4, and this is the golden rule, perhaps the most important rule of the entire procedure, you pull the bioptome back into the sheath with the jaws closed.
You never, ever open them on the way out.
Never. If you open them, that tiny, precious piece of heart muscle you just harvested, probably only 1 to 3 millimeters in size, washes away into the bloodstream. That's an embolus. It can go to the brain. You have lost the sample and potentially caused a stroke. You hold it tight until it's out of the body.
And you have to do this. How many times for it to be a valid test?
The standard is at least 5.
5 successful bites.
Yes. The disease might be patchy. If you take one bite, you might just hit a healthy spot and get a false negative. So you need a representative sample. You take 5 to 7 samples from slightly different sites to be sure.
Wow. That leads us perfectly into what you call the biggest controversy in this field. Part 4. The great debate. Right ventricle versus left ventricle.
The classic dilemma. It's one of those things cardiologists argue about at conferences all the time.
For decades, the right ventricle, the RV, was the default. Why was everyone so focused on the right side?
It boils down to anatomy and physics.
No.
To get to the right ventricle, you go through a vein, usually the jugular in the neck or the femoral in the groin. Veins are low-pressure systems. If you poke a hole in the vein on the way in, you hold pressure, it stops. It's forgiving.
And the destination is easier to get to.
Much. You just follow the flow of blood right into the RV. You aim for the interventricular septum, the wall separating the two chambers. It's a pretty straightforward shot. And the crucial point, if a clot forms on the right side and breaks loose, where does it go?
To the lungs.
A pulmonary embolism, which is bad, don't get me wrong, but it's rarely instantly fatal or as permanently disabling as a massive stroke. So the safety profile regarding emboli is much, much better on the right.
There's a big downside. There has to be.
There is. The right ventricle is thin. It's like a sheet of paper compared to the thick muscle of the left ventricle. It is actually much easier to perforate. And here's the kicker. Many of the diseases we are looking for, especially cardiomyopathies and some forms of myocarditis, they have a preference for the left ventricle.
So you are looking for keys under the streetlight because it's brighter, even though you drop them in the dark alley.
That is the perfect analogy. The source paper cites a study by Chimenti et al. That is really damning for the RV-only approach in certain cases. In diseases that predominantly affect the left side, the diagnostic yield of an RV biopsy was only 53%.
A coin flip. You put the patient through all that risk for a 50-50 shot at an answer. That's not great.
It's not acceptable, really, whereas the yield for the left ventricle biopsy in those same patients, 97.8%.
That is statistically undeniable.
It is. That is why the modern approach, especially in high-volume centers, is shifting. We were getting braver and smarter about going to the left ventricle.
So how do you access the left ventricle? You are fighting against the current of blood coming out.
You go in retrograde through an artery, usually the femoral artery in the leg, but increasingly the radial artery in the wrist is becoming popular.
A wrist, that seems incredibly far from the heart and a very small target.
It is, but the radial approach is fantastic for the patient. They can sit up right after the procedure. It bleeds much less. But yes, you have to navigate the catheter up the arm, around the arch of the aorta, and then cross the aortic valve against the jet of blood. It takes more skill.
But the payoff is that the LV wall is thicker.
Much thicker. It's the main pumping chamber for the whole body. It's a huge muscle.
Mm-hmm.
So it is actually much harder to perforate the left ventricle. The perforation risk is lower. The trade-off is the stroke risk.
Because any clot or air bubble on the left
Has a straight shot to the carotid arteries and to the brain.
So it's a trade-off. Higher risk of perforation on the right, higher risk of stroke on the left.
Correct. But with modern technique, meticulous flushing, and good anticoagulation, the stroke risk on the left has come way, way down. It's considered very safe in experienced hands.
And then there is the double-barrel approach mentioned in the review, the biventricular biopsy.
Doing both sides. This is the ultimate in thoroughness. If you really don't know what is going on or you suspect a very patchy disease like sarcoidosis, you do both.
It makes sense. If you only check the living room, you might miss the fire in the kitchen.
Precisely. Biventricular biopsy checks the whole house. It gives you the highest possible chance of finding the answer.
Speaking of checking the house, we aren't doing this blind anymore. This brings us to part 5. Advanced guidance. We have moved past just simple x-rays.
We have standard fluoroscopy, which is just live X-ray, is still the baseline. You need it to see the catheters. And the review gets very specific about the angles right anterior oblique 30 degrees and left anterior oblique 40 degrees.
Why those specific numbers? Is that just geometry nerd stuff for interventionalists?
Chuckles. It is,
Yeah.
but it's safety critical geometry. Those angles allow you to visualize the septum in 3 dimensions. You need to see that your bioptome is hitting the wall perpendicularly at a 90-degree angle.
Why is that so important?
If you come in at a slant, the jaws will just slide off. We call it skeeving. You won't get a sample. And worse, you might slide right into the tricuspid valve apparatus and tear something.
So the angles ensure a clean, safe bite. What about echo? You mentioned that before.
We often use transthoracic echo right there in the lab during the procedure.
Yeah.
It's mostly for safety monitoring. If you do poke a hole, the echo will show the fluid, the pericardial effusion building up instantly. It's your early warning system.
But the real sci-fi tech here, the thing that feels like a huge leap forward, is electroanatomical mapping, or EAM.
This is the game changer.
Yeah.
This completely changed the game for diagnosing patchy diseases.
Yep.
It's like using a metal detector on a beach instead of just digging random holes.
Break that down. How does that work?
Okay, so healthy heart muscle conducts electricity very well. When it depolarizes, it creates a strong electrical signal. It has high voltage.
Right.
But scar tissue, dead tissue, or tissue that's infiltrated with something like amyloid or fat, that tissue is electrically dead. It conducts poorly, it has low voltage.
So before you even think about taking a bite, you create a voltage map of the chamber.
Exactly. You put a special mapping catheter in and you touch it to dozens, sometimes hundreds of points on the inner wall. A computer then builds a 3D color-coded model of the heart. Usually, healthy tissue is colored purple and scar is red or gray. You can literally see the dead zones.
And then you just drive the bioptone straight to the red zones.
That's it. Instead of taking 5 blind bites and hoping you hit the disease, you can take 2 or 3 bites targeted precisely to the areas you know are abnormal. It increases the sensitivity of the test massively.
Sounds incredible. What's the downside?
It adds time to the procedure, it adds cost, and it requires special equipment and training. But for diseases like sarcoidosis or arrhythmogenic cardiomyopathy, it is the difference between a diagnosis and a misdiagnosis.
Let's bring all this to life. The review includes 2 case studies that really illustrate why all this technical detail matters. Part 6, Case Studies in Action.
These are perfect examples of how the biopsy guides you down 2 completely different paths.
Case 1 is a genetic detective story. We have a 32-year-old male, young, healthy guy.
Very young. He had what seemed like the flu-like symptoms, palpitations, a typical viral prodrome. But he doesn't get better. He gets worse. He crashes.
And he ends up in the ICU.
He ends up in the ICU in cardiogenic shock with an ejection fraction of 12%.
For context, normal's around 60%, so 12% is a heart that is barely fluttering.
It's barely moving. He is so sick, he's on an Impella, a micropump inserted to his heart, and also on ECMO, which is full heart-lung bypass life support. The doctors are thinking, this kid has fulminant myocarditis. His heart is massively inflamed.
The natural instinct is give him steroids, suppress the immune system.
That's the textbook response. But they were smart. They did a right ventricle biopsy first while he was on support. And guess what the pathology showed?
No inflammation.
0. No inflammatory cells. None. So if they had given him the high-dose steroids...
It would have been completely useless and just exposed him to a huge risk of infection, especially while he's on echo with all those lines in him.
Exactly. Instead, the biopsy showed massive fibrosis, just widespread scarring. That prompted them to do genetic testing, which later revealed a mutation in the Titin gene, TTN.
So, a genetic dilated cardiomyopathy.
Yes. It wasn't an acute inflammatory attack. It was a chronic genetic failure that finally decompensated and tipped over the edge. Because they knew it wasn't inflammation, they just focused on mechanical support and standard heart failure medications.
And the outcome.
He recovered. After a year, his EF was back up to 55%. The biopsy saved him from the wrong treatment. It told them what not to do.
That's an incredible story.
Okay.
So case 2 is a flip side of that coin, the hidden inflammation.
This is a 40-year-old male, comes in with chest pain, also in cardiogenic shock, EF of 25%, so very sick again. But his ECG had a key clue, a left bundle branch block.
And that electrical block points to a problem specifically in the left ventricle.
Correct. It suggests the disease process is predominantly on the left side. So they made the right call. They went for a left ventricle biopsy.
And what do they find?
They found the smoking gun. Severe inflammation with a very specific type of cell. Natural killer CD16 plus lymphocytes. And, this is the crucial part, the viral PCR on the tissue was negative.
No active virus.
No virus. So this is autoimmune myocarditis. The body is attacking itself. This is the exact scenario where it is safe and necessary to use immunosuppression. They gave him cortisone and azathioprine.
And the result for him?
Complete recovery. He was discharged from the hospital in 15 days with a normal EF.
That is just. It's the power of this procedure in two stories. In case one, it said, stop, don't use those drugs. In case two, it said, go, use those drugs now. Without the tissue, you are just flipping a coin with the patient's life.
It validates the entire invasive approach. You cannot manage these critically ill, undifferentiated heart failure patients blindly. You just can't.
Now, you mentioned CD16 plus lymphocytes and viral PCR. This brings us to part 7, pathology. It's not just about getting the chunk of meat. It's about what you do with it in the lab. The review is pretty clear that the old Dallas criteria are dead.
Oh, they're dead and buried. And for good reason. The Dallas criteria were from the 1980s. They relied on a pathologist just looking at a standard hematoxylin and eosin slide and saying, yeah, looks inflamed to me.
It was subjective.
Incredibly subjective and just not sensitive enough. You'd miss a lot of cases. The modern standard is immunohistochemistry, or IHC.
What is that exactly?
We use special chemical stains, which are basically antibodies, that attach to specific protein markers on the surface of different immune cells.
Right.
We can light up and count exactly how many T cells are there. We look for CD3, CD4, CD8 to see the T lymphocytes. We look for macrophages with a CD68 stain. We can even look for HLA-DR, which tells us the immune system is actively turned on in that area.
So you're not just guessing if it's inflamed. You're getting a specific cell count and identifying the culprits. It turns a blurry photo into a high-res digital scan.
That's a great way to think about it. And we combine it with viral PCR. As we said, there's the viral DNA in there, parvovirus B19, HHV6 adenovirus. That distinction is binary. Virus present generally means no steroids. No virus present means steroids are on the table.
And for amyloid, is it a similar process?
It starts with a classic stain called Congo red. Under polarized light, amyloid protein glows with this beautiful, almost eerie apple green birefringence. It's striking to see.
But that doesn't tell you the type.
No. For that, the gold standard now is mass spectrometry. We actually take the tissue, extract the protein, and run it through a machine that tells us the exact molecular weight of the protein fragments. That tells us with near 100% certainty if it is TTR amyloid or AL amyloid.
Again, precision.
Because they have totally different chemotherapies. One is a death sentence. If misdiagnosed, you have to get it right.
So looking forward, the final section of the paper, Part 8, deals with future perspectives and logistics. It suggests this procedure shouldn't be done in every community hospital.
No, absolutely not. They strongly advocate for a hub-and-spoke model. EMB is a low-volume, high-risk, high-skill procedure. You don't want to be the patient of a doctor who does one of these a year. You want the doctor who does 50 a year.
So the smaller hospitals, the spokes, should identify these complex patients and send them to the major centers, the hubs.
Exactly. Centralize the expertise. That's how you keep complication rates low and diagnostic yield high. They also push for simulation training.
Practicing on dummies.
High-fidelity simulators. Doctors should be crashing virtual planes or perforating virtual hearts before they touch a real patient. It's the only way to maintain skills for a procedure you might only do a few times a month.
And on the technology front, what's next?
The future is hybrid imaging. The idea is to merge the data from an MRI, a PET scan, and an electrical map like EAM into one single fused 3D superview of the heart.
To give you the ultimate treasure map.
Exactly, to guide the biopsy with unprecedented precision, and then going even deeper, using the tissue for genetic analysis, not just for diagnosis, but to look at gene expression profiles, something called transcriptomics, to tailor therapy to the individual's unique molecular signature.
So we are moving from what was once a blind bite in the dark to what is now a laser-guided molecular analysis.
That is the trajectory. It is becoming less of a simple procedure and more of a precision diagnostic platform.
To wrap this all up, we started by calling this detective work. After going through this, I think the verdict is in. It's dangerous, it's invasive, and it's technically demanding. But for that patient lying in the ICU with a failing heart and no clear answers, it is the only path to the truth.
It shifts the diagnosis from heart failure, which is just a label for being sick, to a specific disease with a specific cure. It saves lives by providing the one thing every doctor needs and every patient deserves: certainty.
It really makes you rethink what's possible. It's not just managing a condition, it's about potentially curing it, but only if you're brave enough to go look for the answer.
That's the heart of it right there.
A perfect place to leave it. Thank you for joining us on this deep dive into the microscopic world of the heart.
My pleasure. It was a great discussion.
And to our listeners, keep asking questions, keep looking for the why behind the diagnosis. Thank you for watching The Funnel Effect.